Assalamu alaikum. This is Sayyida Sania Fatma from 3rd Profession, Section B, Group number 15. Let's start our presentation with the recitation of Surah Khaf, ayat number 59 and 60. उर्दू तर्जुमा। और ये बस्तियाँ हमने तबाह कर दी जब उन्होंने जुल्म किया और हमने इनकी बर्बादी का एक वादा रखा था। और याद करो जब मूसा अलैहिस्सलाम ने अपने खादिम से फरमाया, मैं मुसलसल सफ़र में रहूँगा जब तक दो समंदरों के मिलने की जगह न पहुँच जाऊँ या मुद्दतों चलता रहूँगा। हदीस नबी सल्लल्लाहु अलैहि वसल्लम है कि हज़रत अब्बास बिन अब्दुल मुत्तलिब से रिवायत है कि मैंने रसूल अल्लाह से सुना, आप फरमाते थे कि ईमान का मज़ा उसने चखा और उसकी लज्जत उसे मिली जो अल्लाह को अपना रब, इस्लाम को अपना दीन और मोहम्मद सल्लल्लाहु अलैहि वसल्लम को अपना रसूल और हादी मानने पर दिल से राज़ी हो गया। Now move towards our case study of a lipid and coagulation profile. Case number 1 is related to 63-year-old Hispanic female. Her blood pressure was 142/86 mm of Hg. Due to elevated blood pressure, her doctor recommended her to do lipid profile test. The test results show mixed dyslipidemia with LDL-C of 110 mg per dl, HDL-C of 49 mg per dl, and triglyceride level of 185 mg per dl. Her medication was amlodipine 5 mg per day and pravastatin 20 mg per day. Family history: both the parents developed type 2 diabetes mellitus and ASCVD in their early 60s. Complication is that the patient reported that she didn't feel good on atorvastatin 40 mg per day, but she is also hesitant to try third statin, and she also said that they might cause her diabetes and is concerned that statin is putting her at a higher risk of diabetes because of her family history. So the doctor prescribed her to do more lab tests, which results are fasting blood glucose level 101 mg per dl, HbA1c level is 5.9%, serum creatinine level is 1 mg per dl, urinary analysis and hepatic transaminases are within the normal limit, whereas BMI is 31 kg per meter square. Other lab results are waist circumference 91.5 cm. There is no traces or history of tobacco and alcohol intake, whereas patient's 10-year ASCVD risk score is 7.8%. Conclusions were made according to the test result. Under the guidelines of the management of the blood cholesterol, a patient is considered as a intermediate risk patient because of her 10-year ASCVD risk score, which is greater than or equal to 7.5%. Her risk score and the presence of a risk enhancer indicate the need of a moderate intensity statin therapy to reduce the LDL-C by 30 to 49%. Now case number 2. It is also related to a lipid profile. A 12-year-old male present to the lipid heart clinic for the evaluation of mixed dyslipidemia. Patient history: patient has had his lipid first check at the age of 10 as a part of a universal screening, and at that time his triglyceride levels were elevated to 231 mg per dl, and he is also told to work on his diet. But the lab results were not rechecked till 2 years later. The patient's mom noted he had a significant weight gain over the past 2 years. Family history: history is unremarkable for the early heart disease or hypertriglyceridemia. Physical activity of that he doesn't participate in sport, but he has a gym classes daily and rides his bicycle in the summer. His sedentary time is 2 to 4 hours daily. Some physical examination reveal his height is at 57th percentile and weight is at 97th percentile. Due to this, we are placing him in the obese category. Blood pressure is 107/64 mm of Hg, whereas pulse rate is 89 beats per minute. Notable examination findings include faint abdominal striae. Some laboratory examination fasting lipid panel reveal total cholesterol level 238 mg per dl, which was elevated. HDLC level was 39 mg per dl, LDLC was 199 mg per dl, and triglyceride level was 449 mg per dl. So for management and treatment, no medication is prescribed as the patient was young and he could control his diet to control his body cholesterol level by doing exercising and managing his diet. Patient follow-up. 6 months later, the patient returned to the clinic and he stopped drinking sugar-sweetened beverages, changed to skim milk from 1% milk, and increased his vegetable intake. He had joined a soccer team and also lost 15 pounds of weight. Now, the recent lipid panel had almost entirely normalized and showed result as total cholesterol level 170 mg per dl, HDLC level was 40 mg per dl, LDLC level was 102 mg per dl, triglyceride level was 139 mg per dl. Now move towards our next case, which is related to a 44-year-old obese man who has no history of coronary artery disease but having a complication of a deep vein thrombosis in last 3 months. Social history: he drank 2 cans of beer a day and smoke a half pack of a cigarette a day. Family history revealed his father has a lipid disorder and his mother had a myocardial infarction at the age of 50. Physical examination revealed that the patient's heart rate was 84 beats per minute and his blood pressure was 145 by 101 mm of Hg. Weight of patient was 302 pounds and waist circumference was 43 inches. Due to deep vein thrombosis, the patient is taking medications like warfarin 5 mg per oral daily, hydrochlorothiazide 25 mg per oral daily, and multivitamins with minerals daily. Lab reports: fasting lipid profile tests reveal total cholesterol level which were elevated to 25 mg per dl, triglyceride level 350 mg per dl, LDLC was 143 mg per dl, and HDLC was 42 mg per dl. Fasting glucose level was 120 mg per dl, whereas alanine transferase was 42 U per L. Aspartate transferase was 45 U per L. Total bilirubin was 0.9 mg per dl. Amylase was 95 IU per L and INR was 2.7. Treatment: Gamifibrazil 600 mg per oral twice daily were recommended to the patient to reduce the amount of cholesterol and triglyceride in the blood. Next case is related to 62-year-old man who was initially seen in the emergency room complaining of difficulty with speech and swallowing due to an enlarged tongue. Physical examination revealed his large tongue is due to large sublingual hematoma. In addition, multiple ecchymosis of his skin are also noted. History: he has no history of trauma, nor have there been any previous episodes of bleeding. Coagulation studies show platelet count 1,80,000 per microliter, prothrombin time 12 seconds. Active partial thromboplastin time was 72 seconds. Thrombin time is 10 seconds. Fibrinogen to 25 mg per dl. Laboratory study reveals patient plasma ratio 80%, 50% and 20%, whereas repeated APTT value was 72 in the first time, then 70 in the second time, and then 68 in the third time. Diagnosis: and the results show that the patient has a prolonged APTT value considering the reference range to be 30 to 40 seconds, but our patient APTT value lies between 72 to 68 seconds. The probable cause of the result could be due to a deficiency of one or more coagulation factor, intrinsic or common pathway factor, or heparin therapy, or vitamin K deficiency, or it might be due to liver disease. Treatment. Treatment will be given according to the root cause of the prolonged APTT failure. If it is related to a coagulation factor deficiency, then the coagulation factors are injected into the patient veins at the time of bleeding or before any surgical procedure. If it is due to vitamin K deficiency, then vitamin K supplement is prescribed to a patient. If prolonged APTT failure is due to hepatic disorder, then first liver test is performed to tackle the disease, then treatment would be suggested accordingly. Our next case is related to a 14-year-old female arrived at the emergency room with her mother and grandmother complaining of heavy menstrual bleeding. Patient history was reported by her mother, including a history of a bleeding problem for which she had been treated a few times since age of 4. Petechiae were noted on the girl's abdomen, arms and thighs, and there is no history of aspirin and other NSAID use, whereas the blood work was ordered. Some diagnostic results are WBCs are 10.4 exponent 3 per microliter, RBCs was 3.2 exponent 6 per microliter, hemoglobin was 8.5 grams per deciliter, hematocrit was 25.1%, platelets was 130 exponent 3 per microliter, prothrombin time and INR. Prothrombin is 11.7 and INR is 1 second, whereas APTT value is 29.6 seconds. Diagnosis. Platelets estimate was slightly decreased, with the giant platelets noted. The physician suspect an inherited platelet disorder, and the patient was referred to the hematologist for the further workup. Her peripheral smear noted giant platelets. Laboratory tests confirm a diagnosis of BSS, Bernard-Soulier syndrome. What is Bernard-Soulier syndrome? It is a rare inherited blood clotting disorder that is characterized by unusual giant platelets, thrombocytopenia, and prolonged bleeding time. Affected individual tends to bleed excessively. These are some microscopic result of the giant platelets on peripheral blood smear. These purple color are platelets and they are giant in size. Management. Patients do not require routine prophylactic treatment, so the management of BSS, Bernard-Soulier syndrome, focuses on a prophylactic treatment before certain procedures or after injuries. First advice is given to the patient not to take NSAID. Second, the patient should be advised that the treatment may be necessary prior to the procedure or in response to the common bleeding events such as bleeding gums or epistaxis, etc. Whereas for treatment, antifibrinolytic therapy can be used in bleeding episode. Platelets transfusion are also considered for the patient before surgery or if antifibrinolytic therapy have failed. For several cases, stem cell transplants have provided a cure as well. These are the references from where I extract out all these cases. And lastly, thank you.